You know, radiation is used for a lot of different types of cancers by itself in conjunction with chemotherapy or surgery. For prostate cancer, a lot of the times it's either by itself or with hormonal therapy, because we have studies that show for the right subgroup of people that combination is better than maybe radiation alone. Really there's a lot of facets to radiation oncology. So when we subdivide them, we have external beam radiation therapy and internal radiation. The external beam is what we hear most of the time when someone opts for radiation, and it's essentially radiation coming from outside a machine, not unlike just a routine X-ray. So nowadays, the way we plan and deliver radiation has become so sophisticated that we're able to provide higher doses to the prostate while limiting the dose to the neighboring normal cells around the bladder, the rectum, and the bones. So obviously the objective is to improve our chances of cure, but limit the long-term side effects. So that's what we do with treatment designing. We're determining what angles the radiation has to stop and start from around your body to consolidate the dose on your prostate and avoid your other organs. Once you actually get started, it's essentially like having an X-ray. You lay on a table, the machine rotates around you, it doesn't touch you, you don't feel anything. You're on the table for maybe 15 minutes, and then you're up out doing whatever you normally do. So the typical advantage of external beam radiation is that it's non-invasive, so there's no recovery, there's no cutting, and typically doesn't affect the rest of your daily activities. So people drive themselves, people work, people exercise, and we've had some patients not even tell their closest family members they were getting radiation because most cases you wouldn't even know. The downside of the radiation is that it's a daily treatment. So it's Monday through Friday for right around 8 weeks. And that's based on what we know is most successful but also safe for, again, the neighboring organs like the bladder and the rectum. So, you know, sometimes patients will say, you know, I work from 6 a.m. to 8 p.m., so probably not a great candidate for this type of radiation, whereas other people would say, I don't mind driving there every day if that's what will allow me to avoid, you know, more invasive procedures. The second type of radiation is called brachytherapy, or the seeds or the pellets as we commonly know it. And that's a way of basically putting radioactive seeds directly into the prostate. So it's a 1-hour procedure in the operating room under ultrasound guidance that, according to a predetermined plan, allows us to place these seeds directly into the prostate. And what happens over the next few months is these seeds are decaying and giving off radioactivity, killing the bad cells, but allowing the good cells to repair themselves and replace themselves to prevent long-term injury. So it's somewhere in the middle in terms of invasiveness, where it's not as invasive as surgery, but a little more invasive than radiation. But the better profile in terms of only having to go one time as opposed to, you know, the 30 to 40 times with radiation makes it more desirable. So again, depending on the PSA, the biopsy results, that really determines who the good candidates are for cryotherapy, for radiation, for surgery, and for the brachytherapy. So again, you know, having a multidisciplinary team discuss those options with you, having a surgeon and a radiation oncologist, and sometimes even a medical oncologist as a tiebreaker. And getting second opinions is also very important. And you know I'm never offended if someone sees me first and wants to get a second opinion. As long as you believe in what you're saying, you shouldn't get offended. So I always encourage that, because, you know, having two voices and knowing where your comfort level it is, and it may help clear up some of the confusion.